Forbes Books presents Sustainable Leadership and Disruptive Growth with David Radlow. Transformation for a new and better world. Here's David.
This week, Dr. Vanila Singh joins me on the podcast. Dr. Singh is the former Chief Medical Officer of the Department of Health and Human Services and a clinical associate professor at Stanford Medical School. She has over 25 years of experience in the medical field and is known as an expert on pain management in the illicit opioid epidemic. Dr. Singh, welcome to the show.
Hi, Dave. Hey, thanks so much for having me on. I'm excited to be here.
Let's start by talking about over 50 million people with chronic daily pain and 20 million with high impact pain. Who are they? Why are so many people dealing with pain?
Yeah, great question, Dave. This is like really an ongoing public health issue in our country that often goes unrecognized. It is the invisible disease. It afflicts everybody, chronic pain. And it's a very generic term that encompasses so many pain conditions. We always hear about low back pain, sciatica, some of the common things, but there's a lot of disease processes that afflict a lot of people that affects their lives pretty tremendously. And that's why you have such a large number, because as a nation, many, many years ago, we realized wisely that there's great value and ethics and compassion in recognizing pain and then trying to help solve and manage it so people can lead their lives. It also has economic effects, work productivity, and of course, quality of life measures. So lots of people out there for lots of reasons.
You often talk about a more patient-centered approach with not one size fits all.
You know, chronic pain doesn't sound like a very glamorous health issue to talk about. It certainly hasn't had the interest that, say, heart disease or cancers correctly have, but it is actually insidiously, in some ways, far worse. People live with these painful conditions for many years. And as I mentioned, it affects their day-to-day lives. It affects their ability to work or pursue their career goals, their financial goals, take care of their kids, and manage a life if it goes untreated. It also brings on anxiety and depression for those very reasons. And so it can be a very, very challenging condition. And I've spent my career over 20 years in this field, and I've really had the honor and pleasure to meet so many amazing people, including our veterans. If you think about phantom limb pain, for example, it was well described in the Civil War when soldiers would have their limbs amputated traumatically, and they would develop this sensation of where their limb was and have pain in that limb. And many people thought, well, this has got to be crazy. But in fact, there's physiologic reasons why the brain does that. And learning to how to help them either prevent it or manage it has been vital for so many of our veterans who also suffer from so many other injuries. And so when you take the whole gamut from young soldiers who come back from war and have a tremendous amount of diseases to people who, because of their work or their genetics or congenital issues, have back pain or have systemic diseases like lupus. We've heard of multiple sclerosis. These are neurologic or inflammatory diseases that cause all kinds of difficult, painful conditions that are not easily treated. You really can't have a one-size-fits-all approach. What I mean by that is that each one of us as individuals are unique. We're unique because not only our personalities and where we come from, but also because of our genetics, our physiology, how our body metabolizes or digests, how our cultural beliefs affect our own perception of pain. Some people feel very weak and hide it and really suffer in silence, and more damage is ongoing. But what we really need are people to realize that a full toolbox, a variety of different treatments is what's necessary. And oftentimes it's not just one treatment. It's not just a medicine. It's not just acupuncture. It's not just physical therapy, but it's often a combination of these things because it's so devastating to the body. You have to really take into account the biomechanics, get people functioning again, limit their suffering so that they feel better, but also so they can endure those things. Procedures, interventions that are non-surgical are really on the cusp of cutting edge. And we have spinal cord stimulators, peripheral nerve stimulators. They sound very fancy because they are, but they really break up and change the way the pain is interpreting long-standing pain that is not masking something else. The pain itself is the disease. It's the neurons, the nerves, and the way that the body is interpreting all that. That's the disease, and it's about getting to that so people can live their lives. They can hold on to their job and remain productive, really content members of society.
In your role with HSS, you played a big part in shaping the department's opioid policy recommendations. What were you seeing in the gaps of the existing policies?
Yeah, so thanks so much for bringing that up. The U.S. Department of Health and Human Services is like, I think, second only in budget to the Department of Defense. So going there was an incredibly humbling moment. And as a physician and someone who has taken a great interest in health policy and just in policy in our country in general, it was truly amazing. And there's a host of issues. It was like drinking water from a fire hose. And amongst those issues at that time, President Trump at that time, had declared a public health emergency a few months into my role beginning. That public health emergency was regarding the opioid crisis. And now this was, of course, on the heels of the hurricane that we were dealing with in Houston. And again, there's a host of issues around the country with all disease processes. And I already mentioned like cancer, and then there's dialysis machines, and there's prescriptions. And so this becoming a public health emergency, being declared, that gets, of course, the highest attention. And so being there at that time was incredible because, number one, as an anesthesiologist and further as a pain specialist, I have a lot of experience and expertise in this realm in understanding what opioids are, the good and the bad and the ugly. And so I understood exactly what the president was really focused on in his campaign. He had noticed throughout the country that so many people were taking illegal drugs, and it was rampant. About the same time, just a year or two before this declaration, the CDC in the Obama administration had put out a set of guidelines that were really intended to guide primary care physicians and prescription opioids, so those that are given by doctors or providers in general. And the quick jump was that this crisis was really due to the prescriptions alone. And, there are definitely bad players. I think Purdue has certainly done a disservice. But the situation, as usual, is never that straightforward. It's nuanced. And I realized that the message out there was already clear that this was due to prescribing, overprescribing, doctors, and, they were just giving it like candy. The truth is that there are some pill mills out there, but the vast majority of physicians know that this is a controlled substance officially, and you have to have a DEA license number. And really, what was clear to me at the time was also the threat of the rising illicit or illegal drugs that we were seeing on the streets. We hear about fentanyl. Well, we really put out an APB, if you will, on the illicit fentanyl drugs that were coming in across the border from Mexico and from China at an alarming rate. And unlike any prior street drug crisis that we've seen, and I think of like cocaine in Miami from Pablo Escobar, this was different. And it was rising, and it was going fast, it was available, and it was dirty. It was dirty because it was mixed with all kinds of other dirty street drugs and adulterants that themselves were really bad. So that's kind of the scenario of what I entered into. And there were a lot of interesting agendas. I just wanted to get the real truth at that point, what was really going on in our nation, and get to the bottom of what was perpetuating the overdose crisis from drugs on the streets, and how could we address that.
Who earns the most blame for the pain point? Because if you're in the audience and you're listening, You're trying to figure out if it's the supply, is it the doctors, is it people themselves, or is it everything? And you've mentioned different nuanced factors. How do you simply understand it?
Oh, such a great question. Thank you, Dave, for putting that out there. I would say to your listeners to take a step back and before jumping in and potentially judging a situation, which unfortunately people do, right? They immediately have the worst case belief. The first and foremost important thing is that there are so many tools in the toolbox for pain patients. We need a lot more. Opioids that are controlled and prescribed and manufactured by the companies, they are medical there are medical agents, they're treatments, and they have value. That's important to note. And for many patients who suffer from some of the most complicated diseases, where there's often very little, or there are other treatments, but they don't do as much, opioids have an indication, particularly if the person is getting functional improvement, meaning they can move around more, they can do their jobs, and the people don't have side effects that are limiting to them. And I mean side effects by constipation or nausea or other things. And most importantly, they are not having behaviors that suggest addiction. And I can tell you the vast majority of these people, and many of them don't want to be on medicines that they have to go every 30 days, get it refilled, have to have it checked. They don't like to be stigmatized and counted as druggies or drug users. They have a serious medical problem, more serious than most of your listeners. And this is part of their treatment regimen to keep their lives together. Now, that's one thing. There are those many young people, but maybe other ages too, who were taking advantage of the fact that when you go see your provider, your physician, they're there, they're not law enforcement officers, they're your doctors, and they're to have compassion, and they're trying to care for them. Well, they can malinger, and like I said, it's an invisible disease without often objective markers. When you know somebody's got a well assessed disease, that's one thing, but they would go and take advantage of it and usually would get some opioid like OxyContin, crush it up and snort it. Or they would get it and they would divert it, they would sell it. So there are bad actors there. Those bad actors are horrible because even though they're in the minority, when that stuff gets out, people get very incensed, especially if there's a bad outcome. And, that's how it's getting on the streets, right? Someone's giving it. The vast majority of people who are using prescribed medicines were not prescribed that medicine when they were using it as a drug, not as a medicine, but as a drug. The problem is to understand the differences between the two. There's like no time to talk. It's more sensational to go straight to the diversion and the selling on the streets or the pill mills where those who were writing the scripts very well knew who they were writing to. That's a whole other set of con artists. But what I really want to bring you to, without a doubt, the last few years, it is the illicit drug trade that is 100%, in my view, or you could say 95% responsible for the chaos, the overdose issues of death that's going on in our country. Fentanyl and chemical analogs of fentanyl that are made to go undetected, carfentanil, which is the veterinary, the animal version of fentanyl, which is like really high doses. These are such potent agents that they were never used illicitly because a small amount can make someone stop breathing and it's relatively cheap. So why now, and why is this coming in droves, and why is it being done in such a dirty fashion where it's really meant for anybody and everybody? And it's being mixed with other drugs in other categories. Methamphetamines, cocaine, these are the fourth wave. They're on the rise right now. So it's really the illicit, illegal drugs that have caused the biggest damage in our country in so many ways, not just with deaths, but with people getting addicted, losing their jobs, affecting our country economically. And by the way, it hasn't slowed down at all. We have absolutely open borders to this. And the collateral damage isn't just the direct victims of the street drugs. The collateral damage is also those patients who now, because of stricter CDC guidelines, fearful providers, fearful of the DEA, and state laws that were made to follow the CDC guidelines. The guidelines were just guidelines, leaving ultimately the judgment to the clinician. But state laws were made to mimic that. So it's no longer in the judgment of the physician. These went up. And when people were having incredibly complicated surgeries, had cancer, and this is current, and other issues, it is so difficult to have medically supervised prescription opioids given to those patients where there's means to watch and ensure they're not doctor shopping with the PDMP method, to do random urine screens, and with all the awareness and knowledge we have, they are treated worse with stigma than someone who has addiction and is going into a rehabilitation facility. And we're making almost no headway with the big culprit, which is the illicit, illegal drug trade.
A lot of people, and I shouldn't say a lot of people, have had family members, myself and extended family members, that have had medicine prescribed for a legitimate reason, back issues, other problems over the years. And then at the end of the day, the doctor pulls the prescription because frankly, they can't, it's not working. And sometimes that's when people may go out into the market. The question is, could you kindly look back and comment on the training of doctors and clinicians in practice and what has changed over the years? How was that impacted positively or negatively in this situation?
Yeah, such a great question, Dave. I chaired the U.S. Department of Health and Human Services task force, the opioid and pain task force that was from congressional legislation, the CARA Act of 2016. And it was with the Department of Defense, the Department of Veterans Affairs. We had the CDC, the NIH, the FDA on it, as well as private sector experts, emergency room physicians, pharmacists. We had a primary care doctor. We had a patient on there, pain physicians. We had organizations. We had a lot of support from Human Rights Watch, AMA, and 150 other organizations, including cancer organizations. I mean, it was a huge report that came out that was worked on for 2 years with these experts. And I can tell you, there's no doubt what you're talking about is a big problem where patients are on the opioids, especially of late. Providers are concerned out of fear of losing their license, and they are abandoning these patients. They force taper them. So that's a problem. And after our report, the FDA and the CDC had issued warnings about not doing that, because usually if you're force tapered, many of these patients within 2 years die. And some of that is because they just never are the same and they really can't function and they become depressed. There's a lot of suicide due to pain. This is a really sad but escalating concern. There are a lot of people who then, ironically, who have never broken a law in their lives, suddenly find themselves out of desperation going to the black market. Now think about this. We know that the black market, the street drugs, those illegal street drugs coming from Mexico and China, were and remain a massive issue. I think somebody just now was caught with 20,000 fentanyl tabs, and they were let out on bail free. I mean, this is like poison for the streets, literally. And people under medical supervision, where they're the most safe, where a doctor can say, hey, if they have concerns about someone being addicted, they can help them get to experts where it can be done in a humane manner to help address their addiction. If they're dependent, which is a different thing, dependence is just where your physiological body adapts to seeing the extra source of opioids. You can have a very slow taper if they felt that you needed a lower dose or to come off, while also looking at other options to include. So it should be done at the same time so the person doesn't suffer so much. And I do this often, and it is absolutely feasible when you want to do it. And I do take care of the most complex patients, but we do need more education also. We need more time with our medical students, one, to have compassion, two, to understand the absolute breadth, you mentioned 50 million people. It's actually estimated even up to 100 million in our country who intermittently or have chronic painful conditions, of which 20 million or 19.6 million to be exact have high impact pain where it's affected their lives adversely. It's a high impact on their lives. These are huge numbers, but we have the numbers because we care and we record them and we follow it. There are a lot of countries, most countries, that don't devote resources. They wouldn't ask you your pain number. They wouldn't care that you have pain. They would just kind of tell you to go away after a while. That's why the Human Rights Watch group was interested, because they were very concerned that the movement going on in the country was, rather than getting to the heart of the issue of the illicit drugs and to identify high-risk patients who probably should be monitored very closely if they get opioids at all, this was falling into the vast majority of patients who were not addicted. They were not misusing their opioids. And you need education to understand the difference. It's not rocket science. It's understanding that X could be true. That doesn't mean Y is not true. Meaning people can get addicted. They may have bad outcomes with prescribed medicine. So we have ways to mitigate that risk by identifying what are the risk factors. And in medical school and through residency and other provider like NPs or PAs, teaching them that and showing the different scenarios and not having this mentality that any patient on an opioid is bad. That doesn't have a place in science. It doesn't have a place in medicine, because you can judge people all day long. They have different medical conditions that could be genetic. They could be from an injury or an accident, and they're horrible. So many of these people are disabled. They're handicapped. They have the types of injuries you don't wish on your worst enemies, the types of diseases you don't wish on your worst enemies. And so it is a balance that is necessary. And I think this is really something that applies to all of our society, that nothing is black and white, that there is more to the story. And yes, I think you bring up such a great point that more education is needed. It was highlighted not only for students and soon to be doctors and doctors themselves, but also for patients, so they understand, feel part of this. They're part of an alliance, as well as society at large, and really to take away the stigma, because that is always a barrier to care, and it unfairly judges people without knowing their full situation, which to me is always alarming. And it's sad, because I think we see that in our society everywhere. But when it comes to healthcare, it's not a joke. And so I think that's really what's necessary, is that balanced understanding of different situations and what's likely and what isn't.
Thanks for sharing that. Well, hang on for a minute. We need to take a break. Coming up in the second part of my conversation with physician, educator, and patient advocate, Dr. Vanila Singh, Vanila shares some advice for the next generation of doctors.
Do not be afraid to go against the herd. Never compromise your principles, your beliefs. Hard work cannot be overestimated. No matter what people are saying nowadays, I think it is gratifying, and there's nothing better than being the real deal.
To connect with David, go to davidradlow.com. David's book set, The Principles of Cartel Disruption and Secret Stories of Leadership, Growth, and Innovation, are available wherever books are sold. This has been Sustainable Leadership and Disruptive Growth with David Radlow, a presentation of Forbes Books.